This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
Thank you very much, Darryl. This paper, to my mind, was one of the most important studies in the whole of healthcare over the last 10 years. Because what it says is that, what we all sort of suspect, that people in hospitals are not very good at diagnosing dying. So 1/3 of all MET calls are when people are seriously ill. 1/3 of all MET calls are for people at the end of life. So it's not until they're almost dead that we recognise them. And this was a study done in Australia and Sweden and Canada. And from talking to other colleagues in other parts of the world, it's the same. So doctors in hospital cannot recognise or have a lot of trouble recognising people at the end of life. They're specialists in organs. And if you've got a single organ problem, these are the people you want to see. But if you want someone to stand back and look at this elderly person at the end of life, then they're probably not the ideal people. So putting this into perspective, there's about almost 50,000 rapid response calls per year in my state, in New South Wales, and this is about 15,000 calls are for end-of-life issues. This is a huge, huge unrecognised and unsolved problem. But I think we should quickly move away from more and more studies on the problem and try to move around research about the solution. We didn't anticipate, or I certainly didn't anticipate this when we first started talking about the MET system. We thought it was there to save lives. And it was very soon that we discovered that it not only picked up people who were very ill and whose lives we could save, but you can't die without falling through the MET criteria. It's absolutely impossible. So you also pick up the dying people, whether we liked it or not. People from the intensive care with the diagnosis of dying. So we didn't anticipate this, and now the rapid response concept has led to some of the more exciting research, I believe, in health. So we're beginning to look at the MET system like an extensive triage system. It not only detects deteriorating patients, it sort of decides who comes in and who goes out of ICU, whether they need further consultations, whether they should be considered for end of life, for realignment of treatment, for further investigation. It's more like a triage system, although that's not really how it started. And it's become the surrogate dying team in many cases, but there's very limited linkage to what do you do about it when you actually recognise these people. Because intensive care registrars, intensive care nurses, aren't necessarily trained to begin these very complex discussions. And the home team aren't, and I'm not saying that to criticise them, because we have data. 1/3 of all MET calls are not picked up by the home team. So where do we go now? Well, it's become medicalised, so what do people want? And I sort of think that we need to put much more of a patient carer-centred perspective on this. And we're often speaking about, well, what can we do as doctors and nurses in the health system, without really asking, well, what do people and their carers want? For example, many older people that I talk to do not want to come into hospital, especially in the last few months or year of life. And where do they want to be treated? And how do they want to be treated? So I think it's time that we moved our research into action on the problem that we've got and go to the people. So recognising the people at the end of life, and here I'm only really talking about the elderly, frail people. I'm not talking about younger people with cancer or even chronic heart failure and COPD, although many of those are elderly, frail people as well. So we're not very good at recognising, and we're certainly not very good at responding and treating. So it has to be, and as the previous speakers have mentioned, it has to be patient-centred, and it certainly should be earlier than a rapid response call. This is a crystal tool that we're working on. Now, I'd rather not people think about how exactly accurate this tool is. Every single tool predicting death, there'll be uncertainty. Uncertainties are part of medicine. A 20-year-old with a terminal brain tumour, they want to know how long they've got to live. We might say 6 months, but that's a figure sort of plucked out of the air, looking at a whole lot of them. But it depends on the, on the pathology of the particular tumour and what stage it was picked up. But what we can say is it's terminal, but there'll be uncertainty. And just like the MET criteria, and people still argue about which is the best, it's not really the criteria. It's the fact that you change the culture of the organisation. You suddenly were able to talk about deteriorating patients. Whether respiratory rate was 28 or 30 doesn't matter. And that's what I think will happen with these tools. It doesn't matter that they'll be 100% accurate, because that is not possible. It's just that it will change the culture of hospitals by saying, well, we need to be thinking about this person and whether they've got 3 months, 6 months, 12 months to live or what, and start the conversations. So it's currently being tested in Australia and internationally. It's a retrospective validation initially, and now we're well into the prospective validation studies. It will never be 100% accurate, uncertainty. So the response, just like the MET system itself, and you can see what I'm talking about here, is recognising, responding. A patient-centred, organisational-wide system, like the MET system. And that's not a bad way to approach other patient problems that we have. So the MET system, we can press a button for concern, but we've got no similar button for people at the end of life. Most nursing staff in hospitals know when someone's nearing the end of life, and they probably struggle to understand, why aren't we talking about it? And patients, and someone's mentioned this morning, patients and their carers suspect very strongly that they're, these people at the end of life. So why aren't doctors talking about it? That's another whole question. So the response, and after 2 years of thinking, reading, and talking to a lot of people, we've broken it down, and here I'm talking about our own research, into number one, honest discussion. So we've got a tool which says that you may not be living too long. So why do we keep that to ourselves? So number one is honest discussion with the patient and their carers. Number two, number three, number four is probably the same. And then to then turn it over to patients and empower patients. What do you want? Knowing this information, that you may not have too long to live now, what do you want? Do you want to be continually readmitted to hospital? Maybe that's what they want. Do you want to be managed at home? If so, what sort of support do you need? Do you want to be managed somewhere in between a home and hospital? And if so, what support? Do you want total supportive care, or do you want to continue your tablets? So there is this sort of movement now, not just to have black palliative care or white active treatment. Then you have both. You have a bit of active treatment, but you involve palliative care very early. And that's part of the honest discussion. Now, who should this person be? We've sort of thought about this quite a lot. We can teach every single doctor in every single hospital how to conduct these conversations, and that's probably the ideal and a good way to go. In the meantime, we need someone with skills to talk about this issue. It's not something that's inherent in all of us. And we're thinking about a nurse who is sort of specifically trained, and there are nurses who sort of intuitively have these skills and wouldn't mind this sort of job, and then talks about the choices and power. The choices and power, in turn, will expose what's out there and what's not. So the choices of the patients will determine what's missing in our health system and determine what we should be buying. So it's not only whether people live or die. We're now learning a pretty frightening number of facts about what happens to the elderly frail, the ones who live and leave hospital, and it's a very sobering tale. Many of them are slide downhill into increasing frailty. Many of them have nightmares and all sorts of post-traumatic stress disease sort of symptoms. So that's also what our research needs to follow up. We also need to do much more research on the economic analysis. Community palliative care package, about $6,000 for 3 months. My intensive care beds, $3,000 to $4,000 per patient per day. So we need to throw this in as well. Although this isn't the main driver. The main driver is looking after patients and their carers in a better way. A lot of this, we're thinking that the number of comorbidities or chronic diseases adds up to something that we haven't got a name or a number for as yet. They're sort of medicalised names, but they're age-related, often normal and natural deterioration. And I quite like this word frailty, but a lot more work needs to be done on it. So the most efficient and appropriate response, we need to learn a lot more about this, again from the patient perspective, not ours, but asking the patient how would they like to conduct their journey in the last few months or year of life. And the most acceptable community options. And patient and carer have to be put right in the centre here. So the solution obviously has to be multidisciplinary. The answer is in the community, it's not in the hospital. But most Australians will die in a hospital, so that's a good place to start. It's also the high profile, easy to do research, easy to put systems into place while we determine community answers. But we all know that it has to be multidisciplinary. And therefore the research and the evaluation has to be multidisciplinary. It can't be just randomised controlled trials. There has to be a lot of qualitative research as well. So the International Rapid Response Society is playing a crucial role in this sort of research. And the MET system, the Rapid Response System, is a very important generic model for managing these sorts of patients, recognising and responding, and it's a nice model also for doing our research. So I'll stop there and take questions with all the other panellists. Thank you.